Decubitus ulcer on the foot. What is a decubitus ulcer? A decubitus ulcer, otherwise known as bed sores or pressure sores, occur when there is excessive pressure on skin, underlying muscle, and bone for prolonged periods of time. Irreversible damage may occur in as little as 2 hours of continuous pressure. Reduced mobility and lack of sensation predispose the patient to this condition, and of course it is the direct uninterrupted pressure that ultimately causes the breakdown of tissue. Patients at risk include those who are bedridden or have limited mobility, those with neurological disease, those on medications that diminish sensation capacity, those who are malnourished, those with poor circulation to the affected area, smokers, diabetics, those with collagen diseases such as rheumatoid arthritis, which can result in contractures that put excessive pressure on joints, those that have been on corticosteroids for long periods of time, malignancies, those wearing a poor-fitting cast, those exposed to long periods of cold. Treatment of decubitus ulcer. Treatment of bed sores is twofold in nature. The first is to eliminate the excessive pressure in the feet that is accomplished by offloading where the foot may be slightly elevated off the bed through the use of various devices to lift the legs slightly. The second is the actual treatment of the ulcer. The proper way to assess a bed sore is to look at it from various standpoints. How wide is it? How deep is it? Does the wound appear to be infected? What does the base of the ulcer look like? Decubitus ulcers are generally classified by the amount of tissue damage. Treatment, of course, is predicated by the stage of the wound. Included in the thought process that goes into treating the wound is whether or not the ulcer is infected, which may require antibiotic therapy or at the very least a topical antibiotic cream such as Silvadene, which is a silver-based cream that has been shown to destroy bacteria. If the ulcer contains necrotic tissue, dead infected tissue, that will have to be debrided, removed, by your doctor. Dead tissue harbors bacteria and is an obstacle to healing the wound. Debridement is accomplished in a variety of ways. Use of a scalpel to cut the dead tissue away. Topical creams known as enzymatic debriding creams, which will actually dissolve necrotic tissue. They are generally used in those patients where surgical debridement is not an option. The use of wet to dry dressings, where the dressing over the wound is saturated, generally with saline, and allowed to dry. Once dry, the dressing can be removed, and with its removal will usually take off the necrotic tissue with it. Care must be taken in removing the dressing. Wound irrigation, where the ulcer is sprayed with saline under a mild degree of pressure. Whirlpool treatments attempt to accomplish the same thing as the wet to dry dressing. Sometimes the ulcer may exhibit an eschar or scab which the body actually forms to protect the area. Generally this is not removed unless your doctor suspects the underneath wound is infected. The goal of local wound care is to create an ideal healing environment. That is why infections must be cleared up. Devitalized tissue, necrotic tissue, must be removed as it increases the chance of infection if left alone. Because of the poor consistency of the skin in these wounds, when surgery is required, they cannot be closed by simply suturing the skin back together. Usually a skin graft of some sort will be required. In all decubitus ulcers, ultimately the driving force behind treatment is the progress of the wound in healing. Slow healing of a wound may dictate a change in strategy. This has to be weighed against the overall health and needs of the patient. The best way to treat a decubitus ulcer? Prevention. Read the complete article at www.foot-pain-explained.com/decubitus_ulcer.html